Terrific. So thank you so much for having me. I was really excited and appreciate when the course directors asked me to speak at the conference, and I said yes immediately. This is terrific. I'm super excited. And they said, well, we want you to talk about sepsis. I was like, oh, okay, great. That's terrific. I'm really excited to talk about that. So, well, we'd like you to talk about the Hour-1 bundle, and I started saying, oh boy, okay. And then they said, by the way, we also want you to talk about sepsis and the Hour-1 bundle right after John Safransky talks about the Victus trial and all the work that he's doing. And by the way, Manny Rivers is going to be talking about sepsis too a little later in the day. And then I got really nervous. So I'm curious. I want to start off with a question. So for me, and this is by the way for you, I've already shared my discomfort. So for each of you, the release of the Hour-1 sepsis bundle has prompted feelings of excited clarity, excited confusion, dread and clarity. You know what's going on, but you really don't like it. Dread and confusion, you're upset and you aren't really sure why you're upset, or you have no idea what's going on is the Hour-1. So. Wow, somebody already, wow, that didn't take long. So people have heard about this, right? So, great. So this Hour-1 bundle and sepsis really has had a storm of controversy. There has been, in the popular press, as well as in the scientific press, a lot of articles, a lot of discussion on what do we do with this. Notably, endorsement for this was withdrawn by Society of Critical Care Medicine. IDSA, as you see at the top, just didn't sign on to it and endorse it in the beginning. There's been a lot of things. I do have to point out that for Marvin Singer, he published this before it technically came out, but incestuous amplification is a phenomenal term. And by the way, his #1 reference is actually from Urban Dictionary. So big props for him on that one. So what are we going to do this morning? We're going to talk about what are the elements of that Hour-1 bundle, and then some of the challenges that relate to it. And then perhaps how can we try to reconcile some of this. So what is the Hour-1 bundle? So this is for patients who have sepsis and septic shock, and I'm going to highlight at the bottom, what is time 0, right? So first, it is defined as the time of triage in the emergency department, or if presenting in another care venue, the ICU, the ward, whatnot, from the earliest chart annotation consistent with all elements of sepsis, formerly severe sepsis, or septic shock, ascertained through chart review. So that's what they're saying is your time 0. We're going to come back to that a little bit later. So what should we do? Well, we should measure a lactate. We should remeasure it if the initial lactate is greater than 2. We should get blood cultures prior to administering antibiotics. We should administer broad spectrum antibiotics. We should begin rapid administration of 30 mLs per kilogram of crystalloid for hypotension or a lactate greater than or equal to 4. We should give vasopressors if the patient's hypotensive before or during or after fluid resuscitation to maintain a MAP greater than 65. Okay, so a lot of things that we have been talking about for quite some time, and again, bringing those things together. All right, so we have been talking about this. There has been increasing uptake and increasing use of bundles. For sepsis, we have had the 6-hour bundle which came out in 2004. Just comparing the timelines, again, we want to complete that in 6 hours. Again, lactates, cultures, antibiotics, fluids a little bit lower, that 20 mLs per kilogram of crystalloid, giving pressors and measuring a CVP and SpO2. In 2012, with updates, we now have split that into a 3 and 6 hour bundles. We want to measure that lactate. We want to repeat it now if it's greater than 4. Cultures, antibiotics, fluids. We've increased our IV fluids to 30 mLs, giving pressors, checking CVP. Now this Hour-1 bundle, we are starting it, not completing it, starting it within 1 hour. we're measuring our lactate, repeating it in if it's greater than 2. Cultures, antibiotics, still with the IV fluids, good. And we're going to do pressors. We're dropping the CVP and the SVO2. Okay, so there's been this progression over the last decade plus of what these elements in the bundle should be. So, question for you now. Okay, still going to try working on this, Gabe. Okay, so what is an element in the Hour-1 bundle? Blood cultures after antibiotics, measuring the lactate and remeasuring it if the initial is greater than 2, checking a CVP, SVO2, giving 20 milliliters per kilogram of colloid, and sending thoughts and prayers. And by the way, you can only pick one of this. Perhaps thoughts and prayers are good anyway. Okay, so how are we doing? So, okay, gotcha. So everybody is sending thoughts and prayers. Terrific. Okay, great. So hopefully, hopefully we are not. Hopefully we're picking choice B, which is measuring that lactate and remeasuring it if the initial is greater than 2. Okay. So we have this firestorm. We have lots of controversy about this. How do we think about this? So basically, I consider, what do you need in order to have a fire? Okay, you need oxygen, heat, and fuel. And so I think sepsis is at this crossroads where we have all of these elements that is why we're seeing this phenomena. So we have the heat, we have sepsis being in the spotlight, lots of attention on this. We have oxygen where we're trying to identify sepsis patients, and that has evolved. And then we have evolving treatment evidence as well. I'm going to go into some details related to that. And again, John had mentioned this earlier, sepsis is common, representing 6% of U.S. hospitalizations in 2014, 1.7 million adult sepsis hospitalizations annually in the U.S. alone is deadly, with 15% hospital mortality, again, depending on which group you're looking at, plus an additional 6.2% discharge to hospice, so representing over a 250,000 hospital deaths per year. And it's quite costly, with $23.7 billion spent on sepsis care in 2013. So a lot of focus on this by patients, by advocacy groups, patients, providers, as well as just the press overall. So that we have these payers are paying attention with public reporting. So we have now these SEP1 measures. So again, this is based on that 3 and 6 hour bundle, and we get the wonderful news that 51% of U.S. patients with severe sepsis and septic shock are receiving appropriate care. I'm not great at math, but that means 49% of us are doing it really badly. And we see that across the country, that we have this huge gap between evidence and practice. And as somebody who thinks about the gap between evidence and practice, I feel really bad. When I think about this at Emory, I say, wow, I feel really bad that we're not driving this. And when I talk with people and they say, well, can't we do better? My answer tends to be, it's complicated. And I don't like giving that answer, but I feel compelled to do that. Now New York, with Rory's regulations, came and said, again, with this same 3 and 6, or very similar, 3 and 6 hour bundles, and they put this into regulation for all their hospitals. And so how are they doing? So Mish Levy published in 2018 just an all-comer sort of publication of this, and found that at baseline, they achieved their compliance with a 3 hour bundle a little north of 50% of the time, and 6 hours about a quarter of the time. They did increase over the course of 2 years, but again, that even post, they're not firing on all cylinders for that. So even when it is a state regulation that they need to be measuring this, they need to be reporting, there's lots of pressure and focus on this, they are not delivering this anywhere close to perfect. So the question is it imperfect care, or is it imperfect measure? And that becomes really hard and very difficult to communicate with folks. Okay, so Chris Seymour and colleagues published in a little-known journal, New England Journal of Medicine, in 2017. They looked at this New York cohort. They looked at almost 50,000 patients treated for sepsis in their 149 New York hospitals, and they looked at this time to this bundle compliance within 3 hours. And they really looked at time to complete the elements as well as the overall bundle, and they looked at the effect on hospital mortality. they found that more rapid completion of a 3-hour bundle for sepsis care is associated with a lower risk adjusted in-hospital mortality. You'll see that in the top figure on the right. And so they also found that more rapid administration of antibiotics is associated with lower risk adjusted in-hospital mortality. That's on the lower figure. This is similar to some studies, and we commonly cite Kumar's paper in terms of time to antibiotics. And so we say, okay, well, we have to do better with this. There's absolutely a compelling case on this hour-by-hour effect. But it may not be that simple. And so I want to take a step back and say, okay, well, so how do we define sepsis? So we have sepsis, severe sepsis, and septic shock. So first, the first mention of sepsis was actually in the Iliad in roughly, we don't have the exact date, 800 BC, where sepsis is defined as I rot, which is just an awesome term and definition for that. The Greeks have refined sepsis into perhaps a longer definition, but again, at the bottom, it becomes I rot. So fast forward to 1991, we now have sepsis 1. I guess we were using for ICD 7, 6, etc. We were using I rot as the diagnostic criteria for sepsis. I don't know that. But so sepsis is then now defined as the systemic response to infection. Severe sepsis is now this I rot component, I believe, being infection plus organ dysfunction. And then perhaps really rotting would be the shock component as well. Sepsis 2 refines those elements in 2001. Again, same SIRS criteria, an infection, organ dysfunction, septic shock. And now we have sepsis 3 coming in, swooping in 2016, where we have gotten rid of this severe sepsis. We've shifted things back up, and we have infection plus organ dysfunction being sepsis, and we have septic shock, which is still remained the same. So in conferences and in the literature, we're seeing sepsis 3 definitions. In coding, in pay for performance, in regulations, we are firmly still in sepsis 2 world. And clinicians are firmly in both of those areas because we're not sure. We keep adding this, and we have this discomfort over how do we define patients with sepsis. What about likelihood of infection? So in the Netherlands, they did a study looking at patients who were treated for sepsis in 2 of their ICUs. And they looked at what's the ad hoc sepsis diagnosis, and then they did a retrospective review and looked at and judged the likelihood of patients having an infection. And they found that 43% of patients treated for sepsis were unlikely to have had an infection on post hoc assessment. So we're not really good at identifying patients who have an infection. We make guesses. We prospectively make our best estimates. But we're not as good when we're going back through the hindsight being 20/20. Additionally, they found that mortality was worse for patients who were treated for sepsis when they did not have a definite source of infection as defined on that post hoc review. So people were sick, and prospectively we thought that they may have sepsis, but looking back, perhaps they did not. And when we had that mismatch, patients didn't do as well. So the ED saw the Hour-1 bundle, and they revolted because A, they were not actually consulted in this at all. And they said, well, when patients come into the ED, they often don't meet criteria, and they're absolutely correct. In fact, in this study, they looked at, in a university setting as well as a trauma setting, they found that in 3 hours, looking at a 3-hour mark, 10 to 15% of patients met sepsis criteria after those 3 hours. Okay, so they're missing a significant proportion. And when we look at the median, so the 50% of patients are meeting sepsis criteria within an hour, roughly an hour, after presentation in that university setting. A little bit quicker in the trauma setting, in the trauma unit. Well, that's going to delay your ability to execute a 3-hour bundle. Half of those patients would be completely out of the running for an Hour-1 bundle. So how do we reconcile that? I'd also like to, other aspects that cause some concern is this, that we are trying to extrapolate recommendations beyond what the data support. So even with Chris Seymour's paper, they excluded patients who are outside of the ED. Excluded roughly a third of the patients who are eligible for the study. And so how do we reconcile that? Can we apply this recommendation and extrapolate these data to non-ED patients? I don't really think so. What about those? They also excluded those who had the protocol initiated in a very delayed manner or completed in a very delayed manner. Now, there's a rationale for doing that from a study design perspective, right? You have extreme outliers, and that really can influence your estimates. However, it does have big implications when you're looking at how do you deal with patients where you have a diagnostic uncertainty and you're trying to figure out what's going on, because maybe those patients are actually very different. Maybe we don't know what's going on. We're trying to figure that out. Is every delay bad? And it may not be. We may be actively trying to figure out what's going on with the patients. Additionally, they found that the effect was attenuated in patients without shock. So, for example, initial antibiotics, if you look at the second row or third row on the right, you'll see that initial antibiotics crosses 1 and goes below 1, suggesting that there is not a statistically significant effect on mortality in those who don't have shock. Now, that may be because those patients are not as sick and they have a lower baseline risk of mortality, but they did adjust for mortality, or they did adjust for risk of mortality. So again, that relationship is not as strong as we would perhaps think, and as we see in those who have shock. Additionally, IV fluid boluses, again, also crosses that null point of 1. So is this only in this one study? Well no. In fact, Sterling and colleagues in 2015 looked at this, and they found that they compared time to antibiotics and broke it down as before or after 3 hours, as well as also then before and after 1 hour. And they found that there was no statistically significant mortality benefit. In general, right, so there's a 16% higher odds of lower risk of mortality in patients who have get antibiotics early, right? So, but our statistical certainty of that estimate is diminished, and that's in a very large meta-analysis. What about 1 hour? Again, we also see no statistically significant mortality benefit. So how do we reconcile this? So I'm uncomfortable talking about this, and Haley Gershengorn, they published a grid and a framework which I think is helpful. So on the x-axis we have the likelihood of bacterial infection, and on the y-axis the likelihood of death. Right, so the illness severity. Okay, so how do we map our patients on this? So if you have a very high risk, a very sick patient at high risk of death, and you're certain that they have a bacterial infection, treat them for sepsis. Go quick. If you have somebody who's not sick and doesn't have a bacterial infection, I don't even know why we're talking about them. Okay, right? Why is the patient in the ICU in the first place? Okay, it's really on this yellow line that we need to struggle. Okay, So you've got, in that upper left corner, you've got patients who are sick. They're just not infected. You should treat them, but don't give them antibiotics because antibiotics isn't going to fix them. You know, maybe they're bleeding. That's not going to, you know, antibiotics aren't going to fix that. It's a small amount of volume, right? Treat them for the problem that they have. And you got to look quickly for that. Should you give them antibiotics? Maybe. Where does that line cross? And I don't know. I don't think that we as a field can predict bacterial infection really well. We have uncertainty for this. Okay, and then what about folks where we're certain they've got an infection, but they're at low risk of mortality? You want to target those antibiotics so they don't need to go to the ICU, right? We want to take care of those patients really quickly. How quickly, I don't know. We may not be able to give, maybe we should not be giving broad spectrum antibiotics. Maybe we should be giving focused, targeted antibiotics. How do we balance the need for antibiotic stewardship and targeted therapy for individual patients with we need a shotgun approach to cover something that's big and bad? And sorry, it was Haley Prescott, sorry. So they have said this basically and interpret this into then what about a 1 hour bundle for those who are in that upper right corner, maybe the 3 hour bundle for those who are in the middle, and then intensive investigation for those who are kind of in that red area. And so, as we, I've got one more question for you guys. Hopefully, we'll see how we do with this. Okay, so I'm curious where folks' heads are now. So, do we believe that A, there is irrefutable evidence that antibiotics within 1 hour decreases sepsis mortality? Do we think that B, that evidence that there is evidence that not all sepsis patients meet criteria on presentation? C, that there's perfect alignment between payer, public reporting, and Sepsis 3 definitions on sepsis? And D, a Twitter petition is ongoing for the movie site Rotten Tomatoes to change its name to Septic Tomatoes. The poll is not going to happen. So I'm going to go, everybody went with D, with Rotten Tomatoes. I don't know. Right, so I think that there are questions out there. And I think John has mentioned this earlier. Sepsis is a medical emergency. I firmly, fully agree with that. And I think many in the ICU, the critical care and broader medical community agree with that. I do think that the Sepsis 3 and the Hour-1 bundle are not the end of the story. We need to evolve. I think these efforts move us forward, but I don't think that it's the end of the story. I think we need to go at the right speed when we're caring for our individual patients and when we're influencing the care of patient populations. I'm reminded of Edwards Deming saying that we need to be aware that are we doing things right or are we doing the right things? And we need to be very mindful about that. And we need to structure our systems to optimize care, to deliver care delivery, to minimize unnecessary delays. So when we know we need to go, we should be able to execute without a delay. But there may be a benefit to thinking first as well. So with that, I thank you for your time and attention. Happy to take any questions.